efforts in strengthening their preparedness and response measures. Our collaboration has been instrumental in enhancing surveillance, laboratory capacity, and the effective deployment of technical capacities to countries. Together, we are making progress in containing the spread of Mpox in several affected areas, but there's still much work to be done. Today's briefing serves as a platform to review the current epidemiological situation, share the latest developments, and discuss the strategies that are proving effective in controlling the spread of Mpox. As we move forward, it is imperative that we remain vigilant and proactive in our efforts to combat Mpox. This means not only addressing the immediate needs, but also investing in long-term strategies that will build resilient health systems capable of withstanding future outbreaks and shocks. I would like to express my sincere gratitude to all present, and indeed the partnerships that we have, and to all colleagues who have been working tirelessly on the ground. Your dedication and hard work are making a difference, and together we are making strides towards a healthier and safer Africa. Thank you all for your attention, and I look forward to the discussion that will follow. Let us continue to work together with determination and solidarity to protect the health and well-being of Africa. I thank you.
Thank you, Professor Kasolo, for those insightful opening remarks. At this juncture, allow me to welcome Mr. Jephthah Mpondo, Officer in charge of the UNICEF Liaison Office to the African Union and UNECA. Mr. Mpondo, the floor is yours. Mr. Mpondo? Okay. While we wait for Mr. Mpondo to join, he'll probably join us later. We will move on now into the epidemiological update on Mpox. I am pleased at this juncture to introduce Dr. Michelle Muteba from WHO's Mpox Incident Management Team, who will provide us with the latest updates on the situation. Dr. Muteba, over to you.
Okay, thank you very much, and good afternoon, Chair and dear colleagues. And I really want to show my appreciation for this opportunity that is given to WHO to share the epidemiological situation of Mpox in our region. So I'm going to request if, please, they can project the slide that I've just shared a few minutes ago.
Ask him to just share his screen.
Just share it. Can you share the screen?
Dr. Muteba?
Yes, or I can.
Share your
yes,
screen.
I can share my screen. All right. Then I'll share my screen. All right. I hope that it's visible and it's large mode.
Yes, we can see your screen. Thank you. Go ahead.
All right, thank you. So what I'm sharing here, I think the data that we are using, it's what we have collated so far as of yesterday, the 19th of August. And just a quick overview of the global situation. You can see on your screen that globally, we have already surpassed the 99,000 mark of laboratory confirmed cases, and this is since January 2022 up to June 2024, as we are waiting for data from other regions to be consolidated or compiled at HQ level in Geneva. And in terms of fatalities that are related to these numbers, it's 208 deaths that have been reported globally among cases that lab confirmed. And when you look at the figure you see on your right there, so as of the 30th of June, you can see that in other regions of WHO regions, the number of cases have been actually decreasing. But when you look at what we have in gray, it's in Africa, the African region, the number of cases have been actually increasing monthly. So quickly, just focusing on our region now. So the total number of confirmed cases that have been reported as of 18 of August 2024, it's 4,562. And in terms of deaths that have been reported, 35 of them among the lab confirmed cases. But here I'm not yet mentioning the suspected cases that have been reported to WHO. And when you look at the epi curve, and the epidemiological trend is just showing an increase, especially from January 2024 this year. The number of cases have been increasing monthly. And for the recent 2 months, we're still waiting for countries to submit reliable data, but definitely the trend is increasing. In the past 2 months, we did not record any death reported to WHO except one, but we are still going to update this graph that you see here. Going now to the figures that we have from various countries that are affected in the region. The DRC is definitely the most affected country. When you look at what has been reported so far in 2024, we have 16,123 suspected cases and 558 potential related deaths, related to Mpox. But when it comes to confirmed cases, because we know that it's not all cases that are suspected that are the samples are collected and tested or analyzed. So we have 1,888 confirmed cases and 8 fatalities. But this year, I have to say that we have new countries that have been affected that have never presented any case of Mpox before. These are Rwanda, Uganda, Kenya, but Cote d'Ivoire, it's just a case of reemergence this year. And of course, we have Burundi. And I'm going to go a bit deeper in that in the next slide. But what I just want to bring to your attention here is just in the recent week 32, over 1,000 new suspected cases and 27 potential Mpox-related deaths have been reported in the DRC. Please also note that the proportion of samples that are collected and tested in the DRC falls around 34%. Here we are just giving you an overview of the epi curves, the distribution of cases weekly in the recent weeks in countries that are affected. So 12 countries in 2024 have reported a total of 2,185 lab confirmed cases and 13 deaths. So you can see for Burundi, for example, sorry, I just wanted to have a pointer. So you can see that for Burundi, the number of cases have been increasing in an exponential way, and it's quite alarming. Cameroon has not reported new cases since April 2024. But when we look at the Central African Republic, they have been reporting cases in July. Toward the end of July, there was definitely a peak that they've reached of 8 confirmed cases. But when we look at the Republic of Congo, they have not reported cases since the 17th of March this year. But when we look at Cote d'Ivoire, they've reported cases recently. Only 1 case reported in Kenya so far, 1 confirmed case. And then we have Rwanda that have reported at least 4 confirmed cases, and Uganda 2 cases so far that we have registered. But we hear that there are some suspected cases that are under investigation for the moment. And of course, DRC and Nigeria are countries that are that we said that are endemic when it comes to reporting Mpox cases. Yes, so as I was mentioning here, it just gives you a map of countries that are really that are seriously affected. Those that you see in red, they've reported cases in 2024, and there is active transmission. And you can see, as I was saying, the countries that are newly affected: Burundi, Rwanda, Uganda, Kenya, and Cote d'Ivoire. We do not yet have information so far on the suspected cases that have been investigated in South Sudan. We have heard in the past 2 or 3 days that there were some suspected cases that were also tested in Senegal. And fortunately, I think this morning we received a report that those cases are negative. So we are still awaiting some report from Ghana and Malawi so that we can just give reliable information, but we need to receive official report from countries. Here, I just want quickly to give you an overview on the distribution of Mpox clades in our region. As you know, clade 1B is the most recent one, which is predominantly reported in the new affected countries such as Burundi, Rwanda, Uganda, Kenya, and it came from the eastern part of the DRC, where it was identified last year. So, as I said, the DRC continues to report the highest number of cases with clade 1 spreading beyond its borders, but they also have clade 1A that is mostly prevalent in the northern and the western part of the country. And that's why it's affecting most of the children, those who are below 15 years old. So South Africa reported cases among cluster of MSM and mainly in the urban. I'll come back to that to show you the distribution of these different clades. And maybe here quickly, just to give you the trend in Mpox virus lineage per country in the African region. You can see that we went so far as the 1970s to look at the different strains that that have been analyzed. We have those that we can call out groups that are in red, but you can see how it has been evolving up to 2024, especially in the DRC, but the Central African Republic, but Cameroon as well. And of course, Nigeria, where we say that they are endemic. For all these others, we are continuing to monitor in terms of genomic sequencing of the Mpox viruses. Just quickly on this one, it's just a slide showing the transmission and distribution dynamics of Mpox, but here I'm just going to focus on the countries that have been recently affected. For example, Burundi, we have 23 health districts that are affected, but clade 1, actually, as it's reported, it dispersed across various regions. And there is no significant clustering that has been observed. And of course, it's human-to-human transmission. And so far, there is no confirmed zoonotic cases that have been reported. Rwanda, it's the same. We have clade 1B. We had 3 cases in Kigali, 1 in Rusizi. And these are relatively isolated, but because of the good monitoring and the response, I think the cases are limited. And of course, the proximity with the DRC has led us to suggest that this is a cross-border transmission. Uganda, it's the same, the confined area of bordering the DRC. That's where that case was reported. And it's definitely a cross-border transmission. Uganda, I think the case that, Kenya, the case that was identified 2 or 3 weeks ago was a case that came from someone who traveled to Tanzania. So I'm just quickly going to go, I'm going to maybe some important issues that we need to look at. As I said, for the other countries in the region, we are still monitoring. Now, just in terms of key issues, and these ones are related to the epidemiology and surveillance of Mpox. So there is no clear understanding of the epidemiology in terms of transmission dynamics in all the countries that I've just mentioned. The data that we receive is quite incomplete, and there is delayed reporting due to cases most of the time, especially in the DRC, coming from very remote areas that the access is not easy, and accessing laboratory testing is quite a big challenge. So that's why you understand that there is a delay, and we take sometimes 1 to 2 weeks before the data is updated. And we must also mention that given the stigma and mobility in some key affected areas, the robust contact tracing is not always assured, especially in the DRC. We also have challenges in terms of cross-border information sharing. And in some countries, there is a low proportion of suspected cases that are tested. And here I'm really going to mention countries such as the DRC and Burundi. So there is also an historical endemicity, which means that different approaches to balancing active versus passive surveillance needs to be considered here. I'm going quickly, before I talk about the opportunities, I'll go first to talk about challenges that are affecting other areas. So I talked about inconsistent surveillance and data reporting, but we also have issues in limited laboratory capacities, but also in terms of risk communication and community engagement, there are so many challenges, especially when it comes to the stigmas that we find on the ground and people not sharing information of the contact. A big challenge is the one regarding, the resources and also the competing priorities that we have in the region. We have financial and logistical challenges to the Mpox response. We have limited introduction of vaccine and therapeutics, but I hope that things are going to change now that the threat has been declared. And we have limited funding for specific IPC activities at regional, but also at country levels in countries where the preparedness and readiness and response needs to be normally on top of the game. So there is also a lack of dedicated IPC focal point in the countries. There is a lack of trained readiness personnel in countries. And as I mentioned, competing priorities in terms of diseases and other outbreaks such as measles, diphtheria, dengue fever, without forgetting the humanitarian crisis. In terms of countermeasures, there is a need to support the provision of the supply and provision of PPEs. So the personal protective equipment for healthcare workers, those who are caring for suspected and even confirmed Mpox cases is very important. We, as WHO, are suggesting that the healthcare workers should wear the gloves, the gown, the respirator, and here I want to mention the N95, the FFP2, but also to have eye protection equipment. And all these healthcare workers need to be trained. And on the right here, we are just giving you a list of the support that is needed. So as I said, the provision of PPE supplies to member states, but also supporting countries in conducting trainings, promoting IPC practices, and integration of Mpox response into already existing HIV programs by availing the HR built for these programs. In terms of treatment that is recommended so far, WHO is recommending that we support countries by providing tecovirimat. So we need to promote the use of the WHO Mpox clinical data platform, which has already been created. We need to support member states in pre-positioning available therapeutic doses of tecovirimat for severe cases. So currently, the tecovirimat can be acquired through 3 options. We have the Ministry of Health that could make an application to the MAEU RAI, but also direct procurement or seek donation from a manufacturer, such as the SIGA technologies, but also compassionate use reserved from WHO headquarters. So I'm going to talk maybe quickly. I'm going to skip the WHO proposed interventions here, just to wrap up about the key takeaways from the epidemiological situation in the African region. So We know that the situation is dynamic, and there is a number of additional countries reporting a recurrence of transmission, or it's just the first time. We have this issue of underreporting of actual cases. And so what we have to know is the actual cases are likely to be higher due to underreporting and limited testing. And since the mid of July 2024, the total number of countries affected since the 1st of January has risen from 11 countries to 15. And maybe if cases are confirmed in Ghana and maybe Malawi, we'll have more to add to this list. So the confirmed first clade 1B transmission out the DRC, which while contained in Kenya, Uganda, and Rwanda to date, has resulted in a growing outbreak in Burundi. We are already close to 150 cases. So while the number of affected countries has risen in 2024, the overall number of confirmed cases, except in the DRC, remains relatively low, but it is rising faster. And we just want to finish by saying that the DRC remains the epicenter, reporting close to 90% of confirmed cases in the region. And data quality is often poor, but precise confirmed numbers should be heavily caveated. So I'm going to stop here, and thank you very much. We are available for any question or any precision that is required. Thank you, and over to you.
Thank you, Dr. Muteba, for that comprehensive epidemiological overview, and as well for delving into or highlighting the challenges and emerging issues in relation to the Mpox response. This has been quite insightful, and I'm sure that there'll be a number of questions in the Q&A section of this webinar. At this juncture, I would like to inform our participants that Dr. Tajuddin is unable to join, but very much sends his regrets and will keep up with the discussions following the session. So at this juncture, I'm pleased to welcome Dr. Charles Njuguna, the WHO Regional Advisor on Country Readiness Strengthening. Dr. Njuguna will be delving a little bit more into the opportunities for enhanced collaboration in the Mpox response. So Dr. Njuguna, you have the floor. Over to you.
Thank you very much, Agnes, and thank you, Professor Kasolo. Esteemed colleagues and partners, I'm happy to have this opportunity to share opportunities for enhanced collaboration. I work with the WHO Regional Office in Afro as the Regional Advisor for Country Readiness. I hope you can see the full slide. You are aware that Mpox has been declared as a public health event of international concern by the Director General. This happened last week on 14th of August, and this was based on advisory given by the Emergency Committee. We have frameworks that can help us to do more collaboration with Africa CDC and the other partners, UNICEF and the others. We are aware we have international health regulations that guide us in terms of dealing with public health emergencies, like what we are dealing with at the moment. Within WHO, we have emergency framework that helps us and guides us on how to do response. We have also a joint framework with Africa CDC for emergency preparedness and response action plan. We also have other frameworks that are available even for risk communication with UN organizations like UNICEF and also with IFRC. We have framework for One Health, where we can be able to collaborate with colleagues in animal health. Some of the core components for health emergency preparedness, readiness, and response, where we can be able to look at opportunities for collaboration. We'll start with the issues of coordination for preparedness, readiness, and response, that we can work together as partners to do joint readiness, ensure that even those countries that are not affected at the moment, they are ready to deal with Mpox in case they get cases. We can do joint response planning and also coordination using the established coordination mechanism, and also issues in the area of partnership. There is an opportunity for joint advocacy and resource mobilization efforts. And we are aware that currently, in terms of Mpox response, we have serious limitation in terms of resources that are available. And therefore, we can be able to pull together and be able to support countries that really need this kind of support. We also need to consider how we can be able to monitor the outbreak and also evaluate our response measures, whether they are working and working effectively, or we need to make some adjustment. And having some key indicators that are agreed upon with partners, it will be important to monitor some of these key indicators, appreciating the fact that Mpox right now, it's affecting several countries in our region. The other component is collaborative surveillance. We need to see how best we can do a One Health approach. We know that Mpox is a zoonotic disease, and how we can be able to do epidemiological investigations, ensuring that we improve our surveillance systems. We already have indicator-based surveillance system in the continent, IDSR. We have also event-based surveillance system, which helps us to collect data from formal and informal sources, including the community component. Collaborating on case investigation and contact tracing is very, very important. For even the picture that we see at the moment is not the full picture. My colleague who has made a presentation has indicated that we are lagging behind in terms of even the issues of data collection and laboratory testing. We need to see how best we can do cross-border surveillance, collaboration, and information sharing. For we know that diseases don't need visas to jump from one country to another one. And already Mpox has the potential to spread to other states, member states, through cross-border and also international travel. Laboratories and diagnostics are very critical. The previous speaker has already alluded that in terms of sample processing, testing, we are lagging behind, we are suboptimal. We have an opportunity to collaborate to support countries to improve the diagnostics, and where possible to minimize the distance of specimen referral. We have seen Mpox is affecting communities in remote areas, and taking some of these capacities closer to the outbreak sites, it will help to reduce the turnaround time. There is an opportunity to work together as partners around issues of animal health surveillance and research activities. There are still questions that we need to understand, this being a zoonotic disease. Another important piece is community awareness and protection. We know that every public health emergency, like the one we are dealing with here, Mpox, starts from a community and ends in a community. Ensuring that our communities are at the center of our preparedness, our readiness, and our response is paramount. We need to ensure that we have risk communication and community engagement enhanced, and no one partner can be able to do all this in all these countries that are affected. Therefore, there is an opportunity for us to collaborate in RCCE. We have heard that already we have issues of infodemic, and we need to ensure that we have better management of infodemic, and that calls upon all of us to be able to see ways we can be able to support countries. Issues of public health and social measures are very critical. We remember very well during COVID, we were doing very well, but after COVID came down, people have stopped doing most of those public health and social measures. We need to reinforce them because we know the mode of transmission of Mpox. We need to also support communities so that at their level they can be able to have some level of capacity for early detection and local emergency response, ensuring we understand better about mass gatherings and population movement because they pose a public health risk, especially in the spread of Mpox. And also seeing how we can be able to support countries in terms of strategies for immunization and access to vaccines. The fourth piece is around the clinical care, which is very important, seeing how best we can collaborate in case management, clinical operations, and therapeutics, ensuring also there is psychosocial support to the affected individuals. There is already stigma and discrimination. These are issues that we need to see how best we can collaborate. IPC, very, very critical so that we can be able to minimize the issue of transmission. For those that lose their lives, then again, seeing how best we can have better, safe, and dignified burials. And also, of course, remembering to protect our healthcare workers who are in the front line. The fifth area of collaboration is around access to countermeasures. We know that countries need diagnostics, and also we have gaps in genomic sequencing. We call upon partners to see how best we can support and collaborate around this, and also issues of vaccines and immunization, including demand creation. We have heard about some specific therapies, then how they can be accessible to especially the severe cases will be important. Having at least countries with some doses that they can use for such a cases. We have seen the numbers that we have lost. With time, we are seeing mortality due to this new CRED. Also ensuring that we all work together around issues of operational support, logistics, and supply chain, which are very, very critical. And lastly is around research and development across all areas of work. There is a lot that is not well understood about Mpox, and there are possible areas for researchers to explore, including and not limited to the ones I've listed here: virology and viral origin, pathophysiology and clinical evolution, risk factors and behavioral studies, reinfection and relapse, trying to understand what is happening between these various CREDs, and also the issue of vaccine efficacy trials, communication strategies, but also looking at animal studies in One Health. Otherwise, thank you very much. We'll be ready to take questions also from Afro, together with Dr. Patrick or team, who can also be able to come in and provide some response. Thank you very much.
Thank you, Dr. Jonah, that can hear me. But thank you for our in detail and opportunities for enhanced to ensure a unified, well-coordinated and coherent Mpox response. Now, at this juncture, I would like to, we will now open the discussion. Solo moderate through the questions via the Q&A function. Collated them into all into Portuguese. Please raise so that they interpret question. Juncture, the floor is moderate. Professor Kas.
Number of questions through Q&A. What I'll do, be asking in batches of 5, and then once we go to either if there's a hand raised, we'll go to the hand and then come back to the list. The first question is there is a child?
Sorry, Chair, we can't hear you because it's breaking. We can't hear you properly. We can't hear the question.
You can't hear me?
It was breaking, so we couldn't hear.
Yeah. Okay, so let me go back. With the first question is from me? Sorry, can you hear me?
Yes, now it's clear.
Can you hear me? Okay, so the first question is asking why South Africa has a 12.5% case fatality rate, which is higher than reported in the other countries that have the Mpox circulating. The second relates to the lack of testing capacity in Chad, where the poser of the question is saying they have suspected cases. And the question is, can WHO and Africa CDC please support Chad to have testing capacity? The third is a question reads, is there an epidemiological link between all the cases notified for these different countries affected by the Mpox? Then the fourth is, what is the potential for urban transmission of the 1B clade in DRC? And then the other one relates to lab capacity, which is, can gene expert be used for Mpox diagnosis? We'll pause here and then Dr. Mutabi, I think most of these questions are yours. Over to you.
Thank you very much. So I was actually already responding to those questions on the chat. Yeah, so for the first one, which was asking about why the case fatality ratio is quite high in South Africa. So we, first of all, going to say, in South Africa, the population, the group that is affected is mostly those who are, it was working among a network of MSMs. And because of that, there is always some stigma for them accessing healthcare services timely, on time. But when you also find that it's on the ground of comorbidities, there are some underlying health conditions, and they have access to healthcare quite late, it can lead us to have this number of the high number of deaths in the country. So these are the two main reasons that I'm going to mention here. And now to the following question about supporting Chad on testing. I think WHO is already in the process and has been supporting Chad on that. I think there is a response that has been given by one of my colleagues on the chat. I think they will also come up when it's come to that. But now, on the question about what about the potential urban transmission of the clade 1B in the DRC? Yes, it's a serious concern because everything actually started in a small city called Kamituga, in a mining city where you are going to have a lot of people working in the mines, but also a network of professional sex workers. And that's where I think it started, and it quickly propagated. Those who are working in the sector of hospitality as well, and I mean, in hotels and bartenders, I think that's the way it was transmitted when we looked at the chain of transmission. And of course, it went up to South Kivu, which is an urban area, and then of course it could cross to go to other countries. So the potential of urban transmission is there, and that's why there is definitely a need to support quickly and facilitate actually the control of Mpox even in urban areas. So I'm going also to let my colleague, Dr. Patrick, to respond to some of the questions. Over to you, Dr. Patrick.
Thank you very much, Dr. Muteba, for providing those concrete answers. I just wanted to add one onto the issue of the high CFR in South Africa. And I think we also need to acknowledge the fact that sometimes when you compute percentages for very small figures, it would relatively be high. So when you have 29 cases and you've had 3 deaths, it will when you calculate the percentage, it will give you a higher CFR. But the factors that Dr. Muteba has given have been at play in terms of the issue of access to care for the key population that are affected, and also mostly the issues of underlying condition. And I would like to stress the fact that underlying medical conditions, particularly conditions that suppress the immune system, are critical factors in terms of disease severity and adverse outcomes. And also I would like to clarify, when you compare a HIV patient who has viral suppression and somebody with HIV whose viral load has not been controlled, the person with poorly controlled HIV is at a significant risk of an adverse outcome as compared to the other one. So when we talk about this also, just to clarify that among the people living with HIV, the risk would be of severe disease and death would be very, very high for people with uncontrolled HIV. And then there was the other question that Dr. Muteba, the issue of the epidemiological linkage. So this is a very important area. And as my colleague mentioned, one of the areas that we need to strengthen where we can partner is to properly strengthen epidemiological investigation in the affected countries. So we've been able, of course, to link that like the cases in Rwanda and Uganda and Kenya are linked to cross-border transmission, but we have not been able to fully link which case exactly in DRC or is linked to these other ones that we have And that's the calls for better cross-border collaboration, better information sharing, and joint investigation of cases that have chains extending across borders, so that we can also understand the context of the transmission and some of the factors that we need to take into consideration while designing our messaging, but also while designing our interventions. Thank you.
Very much. We will move on, noting that we have about 15 minutes to go. I'll group some of the questions. One, a number of questions are asking on whether we foresee some travel restrictions coming into effect. Maybe we could refer to the recommendations that was given by the IHR Emergency Committee on that, colleagues. The second relates to the effectiveness of the tecovirimat. The group of colleagues are saying in DRC, they've shown that this particular drug is not effective. Do we have any comments on that? Of course, there are a number of suspected cases being reported across countries. How are we making sure that these cases are not false negative, but rather are positive? Then there's a question for Dr. Juguna. He says, you have indicated that we are limited in terms of resources to fight Mpox. Approximately how much is needed in terms of financial resources to fight Mpox as a continent? In terms of vaccines, how prepared are we as a continent? Then the other one is understanding that Africa CDC could not attend. I think I speak for many partners here that while it is helpful to hear WHO's planning and strategy for partnership in general, it will be very helpful to hear from WHO and AFRO on SCDC's declaration. And this is the public health event of continental security. How specifically are you cooperating with SCDC to complement efforts and not overlap? Will there be a written strategy that outlines this coordination and planning? Have there been any discussions between Africa CDC and WHO on potential of establishing a joint EOC in Addis Ababa? The other question is also talking about will Africa CDC coordinate, and I'll respond to that, especially in respect to vaccine and diagnostic distribution. Then the other one relates to clade 1, and the question relates to how is clade 1 monkeypox spread? And of course, the last one for this block relates to if one received smallpox vaccine in childhood, is he or she currently protected from Mpox? And related to that is a question on the available vaccines. What are the available vaccines? We'll pause here and ask colleagues to respond. Maybe let me start by the question on collaborating with Africa CDC. We are certainly collaborating. We have what we call the Joint Emergency Action Plan, in which we collaborate, a platform in which we collaborate through. And in fact, about a week or 2 weeks ago, we did come up with recommendations on what WHO and Africa CDC should be doing. And this included the development of a joint response plan, but also having an integrated incident management system. And at the moment, I'm told colleagues are discussing on how they are going to deploy the continental incident management system to oversee the continental response to Mpox. So certainly, we are working very closely with the Africa CDC, but we've also in discussion to bring on UNICEF. As you know, UNICEF has a very, very strong logistic platform that can help in procuring some of the countermeasure medicines and as well as vaccines that we've been talking about. So just to say, yes, we continue to work with Africa CDC, and hopefully in the next brief, they will be available to confirm what I'm putting across. Thank you very much, and I'll hand over to our presenters.
Maybe I could start, if you allow me, Professor Kasolo.
Yes, please. Please.
Yeah, thank you very much. In terms of the budget, what will be required, at the moment, WHO anticipates that we need an immediate funding of about 15 million USD or US dollars to support surveillance, preparedness, and response. But this is just an initial requirement. The 3 levels of WHO are doing a needs assessment to see the kind of additional resources that will be required. But there is need to scale up response, and towards that, WHO has already released US dollars 1.45 million to support countries to respond, while we also think that additional resources will be required in the coming few days or weeks. WHO is likely to support from the contingent funds for emergency response to a certain extent, but we are calling upon partners and donors to be able to see how best we can be able to support these countries. Are not just countries that already have confirmed cases. When you look at the map of Africa that we have seen, we see there are a lot of other countries that are at risk, and they need to put in place some readiness measures. We have done readiness assessment in several countries, and there are gaps that are there that those countries need to be able to attend to them, that will require resources. So more resources will be required, but the best thing is to use a no regret approach. Would rather over respond than under respond. Would rather mobilize as much as we can and support these countries to contain the situation than stand and look at things evolving to a situation whereby we require even more resources. Thank you.
Patrick, on the other questions, the effectiveness of...
Yes, thank you very much, Dr. Kasolo, and thanks to the colleagues for these questions. Yes, we took note of the findings from that study that didn't show significant difference in the comparative group in terms of the efficacy, but demonstrated that the safety. And we're just in a meeting with the colleagues from the case management team, and we are looking at this in relation to different studies. There are different studies that are ongoing currently that are looking at the efficacy of the tenofovir in the context of clade 1 transmission, in the context of clade 2 transmission, and then based on the consolidated analysis that will be done, there will be a recommendation or communication coming from WHO based on the analysis of the different studies that are currently ongoing. However, I would also like to hasten to state that the issue currently is the quality of the supportive care remains the #1 priority for case management. That the supportive care, ensuring that there's nutritional support, there's management of the rashes to prevent secondary bacterial infection, and all the symptomatic management that the patients need remain the bedrock of the management of Mpox, and they are associated with very, very good clinical outcomes. And I think the focus should be as well in terms of standardizing and improving the quality of care. The second one, in terms of what vaccines are available, so we know that there are 3 vaccines. The first one is the MVA-BN vaccine, which is made by the Bavarian Nordic. This vaccine has been licensed by a number of countries for use. It's a third generation smallpox vaccine. So it's a live MVA is a live virus, but it does not replicate. So it's one of the vaccines that's been used. We have the one that from Japan, which is the LC16, which is the one that is also recommended for use among children. And then you have the ACAM 2000. Those are the three vaccines that are available. The ACAM is used, the USA emergency use authorization was provided for the ACAM. It's a second generation Mpox vaccine, while the other two are third generation smallpox vaccines. So these largely are the three vaccines that are there. The ones that are being used mostly is the MVA-BN for adults, and also the LC16 from Japan, which is used for children as well. But of course, there are significant limitations in terms of the doses that are available. And as you know, also these vaccines are not yet WHO pre-qualified, and the DG has then activated the process of emergency use listing so that these vaccines can be available as well for use. And then I would like to, I think Dr. Kasolo, you responded to the issue of the collaboration, and it linked to what Dr. Charles was responding in terms of what are the response needs. And I would like to state that in the collaboration we are working on with Africa CDC and our colleagues from the EMRO, we hope by next week we will have a consolidated continental response plan with I think the figures will significantly increase, because we are collating currently working with the affected countries, working with the countries at risk in terms of collating all the response plans from the ministries of health and analyzing and identifying the priority major interventions that should be supported. So to the partners and on the call, I think next week you will be able to receive from us a consolidated continental response plan with more, I think, increased figures based on the rationalization and also inclusion of additional. As you know, as the outbreak evolves, countries have revised their response plans. For Burundi, 2 weeks ago, we were talking of less than 50 cases. Now we are at 153. It's moving exponentially. So countries have had to revise their response plan. The risks have also changed. So these are some of the things that are being factored currently in the planning, which will also drive up the costs for the response. I think those were some of the issue on the testing and false negatives. I think we are using PCR as the standard for testing, and I am quite confident that there are no false positives that are being reported, and that the cases that are confirmed by the real-time PCR are actually positive cases. And of course, as was mentioned by Dr. Muteba, when you look at the suspected cases, sometimes that's why sometimes we don't report fully all the suspected cases, because when you have suspected cases, you investigate, collect samples, then you see in some of the countries that have done in-depth listing, you find what the positivity rate is. But where we are now, we encourage that countries should be able to investigate every suspected case, collect samples, so that we can rule out those that are not Mpox, but also clearly understand the extent of transmission and the burden that is there. Thank you.
So, ladies and gentlemen, I think we had 1 hour of trying to address this very complicated agenda. But just to note that from the questions that we've raised, one of the important take-home message is really the need for collaboration, visible collaboration, where the Africa CDC, WHO, the other UN partners, including civil society and NGOs who are currently working on the ground to respond, that we need to come together, and that through the continental plan that we are working, I think we need to ensure that we cast our net broadly to ensure that all active participants in this response are part and parcel of this particular continental response. It requires, just like we learned from COVID and the Ebola outbreak in West Africa, that it requires everyone and across all sectors to participate in this response. And also that as partners, we need to also define clearly who's going to do what and in which country. And I'm hoping that once this particular plan is shared, and let's keep to our word next week, that all the partners, at least those that are based here in Addis, you will receive a draft copy, if not the finalized copy from us next week. And again, we could reconvene and look at what is it that we can really focus on in supporting our member states address this new challenge in terms of outbreaks on our continent. I would like to thank all of you for participating. Time was short, but I can promise you that our role as the liaison office here will be to continue updating you on what is happening and bringing you together around the table like we have done today to really continue to appreciate the challenges in addressing monkeypox, Mpox, that all of us are collectively responding to. We will share the presentations, and I'll reach out to colleagues in Africa CDC to share their presentation so that we could have one package sent to you that looks at different aspects of this response that we're addressing. So thank you so much, and I hope our colleagues will compile these questions and provide some answers as well to the many questions that we've had. Thank you, and have a good afternoon. There is an evaluation, there's an evaluation that will be sent out in a few minutes. Mohammed, can we have that sent?